Rodriguez? Rodriguez, aye. Santiago? Steinnorth? Aye. Steinnorth, aye. Thurmond? Waldron? Waldron, aye.
11-0. We passed another bill, or we passed a few now. So, Mr. Gomez, please.
Thank you, Mr. Chair. So I'm only going to present one of the two that
Perfect,
I'm currently.
thank you. And then Ms. Waldron's
And then
gonna
I'm
be up.
asking the supporters. Wait a second. We're going to take up AB 2467, not the Healthcare Trust Fund just yet, just because that one is that's the one that hopefully the room clears out after we're done with that one.
The room better not clear out. We still have bills to vote on.
Not members, not members.
Okay, thank you.
Not members. Mr. Chair, thank you so much. Today I'm here to present AB 2467, which would strengthen transparency among hospitals in California by requiring public disclosure of executive compensation. This measure would also ensure pay equity for all frontline health workers. Specifically, AB 2467 would require disclosure of all salaries above $250,000 a year. We also, in conversations with some members in appropriations, we're going to amend it to be above $300,000 a year. So that was kind of an agreement that I was talking to some of the members about, and I think that it still gets us to the point of the bill. Total annual compensation would include wages, salary, and pay time off, bonuses, incentive, lump sum cash payments, severance payments, housing payments, or reimbursement for entertainment or social membership. In order to assess what taxpayers are getting in community benefits or what purchasers are getting in terms of value from hospitals, we need more information. Currently, the state does not have enough information to know how much CEO salaries contribute to spiraling healthcare costs, and where nonprofit executive pay is excessive, or how to assess the potential value or lack thereof of different CEO pay arrangements. Hospitals are the largest healthcare expense category regardless of payer, Medicare, Medicaid, or private insurance, so there is a compelling public interest insofar as hospitals are a driver of overall. Hospitals also play a role in healthcare costs. Here today to speak in support of the bill are representatives from SEI and other labor affiliates, and I'm asking my supporters to be brief as well as the opposition. I greatly appreciate your aye vote. Thank you so much.
Move the bill.
Second.
Approps came in handy. Thank you so much.
Thank you so much, Mr. Chair and members. Michelle Cabrera with SEIU California. We are the sponsor of this bill, and I am going to try to keep it really brief and pass it over to my colleagues, Joan Allen with SEIU UHW and Jessica Stender with Equal Rights Advocates. Thank you.
Thank you for the opportunity to testify in support of AB 2467, which will bring much-needed transparency to how hospitals compensate their employees and executives. This bill arises because the current patchwork of federal regulations regarding disclosure of hospital executive compensation does not provide adequate information for consumers or regulators to make informed decisions. Currently, nonprofit hospitals must disclose compensation to officers and a small number of key employees. But at large healthcare systems, those disclosures barely scrape the surface of the list of highly compensated individuals. There are dozens of executives at California's hospitals who make more than $1 million annually, and hospitals have frequently claimed that such high compensation is justified on the grounds that it increases quality. However, this is not actually the case. A recent study published in the Journal of the American Medical Association assessed the link between nonprofit hospital CEO compensation and various metrics. The study found that hospitals paying their CEOs more than peer hospitals did not provide higher quality care, did not provide more charity care or community benefit, and did not perform better on financial metrics. Unfortunately, the same analysis could not even be performed for California's for-profit hospitals, because for-profit hospital executive compensation disclosure is essentially non-existent. Publicly traded for-profit hospitals are required to disclose compensation for only 5 key executives, regardless of how large the hospital system is or how many facilities it operates. And privately held for-profit hospitals have absolutely no standard disclosure requirements. Additionally, AB 2467 would require hospitals to disclose their executives' participation on outside boards of directors. Board membership is a substantial time commitment and creates the potential for real or perceived conflicts of interest. For example, the CEO of Sharp Healthcare has sat on the board of directors for fast food company Jack in the Box for more than the past 10 years and received more than $225,000 in compensation and stock from Jack in the Box in 2015 alone. Current disclosure of participation in this and other outside boards is insufficient because it is not available in such a way as to readily link the hospital to the outside board on which one of its executives sits. Disclosure of this information would give regulators a powerful tool with which to oversee California's hospital industry. In conclusion, AB 2467 will bring much-needed transparency to hospital compensation for executives and frontline caregivers. Next, I'll turn the conversation over to Jessica Stender from Equal Rights Advocates to describe the need for the bill's demographic reporting requirements. Thank you.
Thank you, Jessica Stender from Equal Rights Advocates. I'll focus my testimony on the pay data collection and reporting requirements. It's well documented that pay disparities exist across various industries, including the healthcare industry, based on gender, race, ethnicity, and other job categories. This is particularly true in the healthcare industry. Specifically with regard to gender, women make up 78% of healthcare workers, yet still face a significant wage gap in various different occupations in the healthcare industry. With regard to nursing, in a study published in 2015 in the Journal of the American Association for Medical, the JAMA, they found that nurses who outnumber women nurses who outnumber men 10 to 1 still face a significant wage gap, with men earning significantly more, $7,000 more in outpatient services and close to $4,000 more a year in hospital settings. This is also true for physicians. A study found that female physicians earn half of what male physicians earn in Medicare systems. The data collection requirements that are in this bill are really necessary because one of the major contributors to the wage gap is a lack of transparency as to what people are getting paid. Many workers don't know what they're getting paid, and employers often aren't forthright with those payment practices. Many times, even well-intentioned employers do not know that there are pay discrepancies. So these kinds of internal, both pay data collection and then also reporting requirements help even well-intentioned employers who may not know that there are pay discrepancies see these kind of larger patterns that exist in these healthcare facilities and thus rectify them. So we urge you to support this bill. Bring greater transparency to these payment practices and resolve these issues that are often unseen. Thank you.
Thank you. Other witnesses in support? Just your name and organization, please.
Pat Whalen, Ellison Wilson Advocacy here on behalf of United Nurses Association of California Union of Healthcare Professionals, a proud member of AFSCME. Strongly urge your support. Thank you.
Thank you.
Tam Ma with Health Access and Support.
Thank you.
Mr. Chair and members, Seth Brownbill here on behalf of the California Teachers Association in strong support.
Thank you.
Sarah Flox, California Labor Federation, in support.
Thank you.
Joe Michael, Equality California, in support.
Thank you.
Georgette Bradford, SEIU UHW, strongly urge a yes vote for 2467.
Thank you.
Stephanie Piazza, SEIU member, Kaiser San Francisco, supporting.
Thank you.
Ivory Evans, SEIU UHW, I support it.
Thank you.
Roberto Ramirez, SEIU member, in support.
Thank you. Anyone else? Opposition, please come forward. Thank you.
Good evening, Catherine Scott, representing the California Hospital Association. Even as amended, we remain strongly opposed to AB 2467. As was stated, there is reporting required. What was not stated is the reporting we currently are required, all hospitals are required to do under the Office of Statewide Health Planning and Development, which features our labor and our administrative costs in a comprehensive report of our labor and administrative costs, where it shows that over 50% of our costs are labor related, and much of those are related to direct service. So our hospitals do report this kind of data in a comprehensive manner and do make this data transparent if you go on the OSHPD website. So therefore, we are concerned that this bill will be duplicative in its nature, along with the reports that are provided, as mentioned before, both the SEC reports and the 990 reports, along with our public hospitals that also report this kind of data. We are concerned that we are reporting data on single hospital employees who make, well, now over 300,000, could reach deeper into the organizations, especially in our urban areas where compensation is higher to compete for our well-qualified employees. Many of our mid-level employees are responsible for managing patient safety, managing skilled employees, making sure they're compliant with state law and government entities, and as well as managing sophisticated technology. This commands a competitive salary, and we are concerned that we're going to be making that information public in a private environment. And this is the first bill that we're aware of that would require a private entity to disclose that information. And we're concerned what it could do to the retention of our current employees, and then, of course, the competition for our employees in the future. We often compete with Fortune 50 and Fortune 100 companies for these employees, particularly in our IT space and in our technology space. In the Silicon Valley, we're competing against some of the most highly ranked companies for these employees. And Jim will talk more about that shortly. We are also concerned about we also want to mention that there's a fiduciary responsibility on the part of the boards to ensure that our executive compensation is at the standard of the industry. So all of our boards do salary surveys and ensure that that their entities are paying at the appropriate rate. We are, in conclusion, we are concerned about the duplicative nature of this. We're concerned about the EEOC reporting and the fact that much of that data is not publicized by the federal government as required, because it's known, it is not known to be reliable. Sometimes our employees have to guess at some of that information, and it's all on a voluntary basis. So the feds don't currently require that that information be publicized because of that reason. So we are concerned about the bill being duplicative. We're concerned about it creating administrative burden, and as Jim will talk about, we're concerned about the effect it could have on our employee retention and recruitment. Thank you.
Thank you. Good afternoon, or should I say good evening, Chair and members of the committee. My name is Jim Goss. I'm a partner with the recruiting firm Witt Kiefer. I've been with Kiefer for over 30 years. We assist employers in a variety of industries, identify candidates for their key positions, including healthcare, insurance, universities, colleges, medical technology, and a variety of other philanthropic foundations. We, as a firm, do work throughout the entire state of California, including rural and urban areas of the state. I am also a very active and former board member of the Institute for Diversity, a national organization committed to advancing diversity in healthcare. Hospitals are among the most difficult organizations to recruit to. As all of you know well, managers in any business have the demands of personnel, of technology, of human resource issues, etc. But all of this in a hospital, of course, occurs in a 24/7 environment. And I would suggest to you that our ability to compete and retain good mid-management workers in our hospitals is difficult to begin with, and I think this bill would make it increasingly difficult. Hospital management must also, as you well know, consider patients, families, the communities they serve, patient safety, which of course we've heard a great deal about today, privacy in nonstop environments. Mid-management clinical executives, such as nurse managers, directors of pharmacy, of which we spend a lot of our time recruiting, have other choices outside of hospitals. Non-clinical mid-managers such as IT, human resources, can really go to any industry. It's why we need to stay competitive, and it's why I believe that AB 2467 will make it more difficult to place candidates in hospitals. As indicated, there really is no other private organization that requires this kind of reporting. I believe firmly that given some of the issues that I've just mentioned, that it will make it more difficult for our hospitals to retain the kind of employees that we're seeking. I think there'll be loss of talent. I think the jobs will become harder to fill. And I think without those unfilled positions, patients may not receive the kind of service in an efficient manner that they expect. Lastly, I'd just like to comment regarding boards. I do recruit board members, voluntary and fiduciary boards, and I will tell you that they are both diligent, comprehensive in their evaluation of both executive and mid-management compensation. And as all of you know, voluntary board positions are unpaid.
Great.
Thank you very much.
Thank you very much. Others in opposition, just your name and organization, please.
Angelica Gonzalez on behalf of Kaiser Permanente in opposition.
Thank you.
Mr. Chairman and members, Nathan Mansky representing Adventist Health and Loma Linda Health in opposition. Thank you.
Thank you.
Mr. Chair, members, I'm Fred Note, representing the Alliance for Catholic Healthcare in opposition.
Thank you.
Ms. Seth Short representing the Peach Hospitals in opposition.
Thank you.
Kelly Brooks representing the Association of California Healthcare Districts, also here in opposition.
Thank you.
Jonathan Clay on behalf of Scripps Health in opposition.
Thank you.
Mandy Lee on behalf of Sutter Health in opposition.
Thank you.
Sherry McHugh representing the California Chamber of Commerce in opposition.
Thank you.
Les Shepard on behalf of Stanford Healthcare in opposition.
Thank you. Questions or
I should say CHA is in opposition, as well as the United Hospital Association. I apologize.
Thank you. Questions, comments, Mr. Dubovny?
Mr. Gomez, I do appreciate working with me on this. I do have a couple quick questions. In terms of an unintended consequence, would you feel it would be a bad consequence if more current nonprofit hospitals decide to go to for-profit or corporate model and left nonprofit status because of this bill?
Chair, if I may, the nonprofit industry is one of several that are being covered under this bill. Currently, nonprofits already have to disclose quite a bit of information about compensation, which is why the California Hospital Association is saying this is in part duplicative. So currently, again, under the IRS Form 990, they already have to report. Publicly traded hospitals have to report under SEC rules, and so there is a segment of what are, for-profit private companies that also are already subject to reporting requirements. What we're really doing here is making the reporting more uniform and also ensuring that, because we've already seen trends in the healthcare market and in hospitals in particular toward consolidation, the existing reporting that was meant to get at what are nonprofits paying executives and is that reasonable is not reaching far enough into the system. So we're only getting the very higher sort of levels, and we're not getting at each individual hospital that composes that system. And so this is really about being more thorough and more consistent on information that is in large part already being collected. So we don't have any fear that this is going to do anything to exacerbate trends that are clearly already underway in the healthcare industry.
And then my one follow-up, and this comes from a conversation I had with policy analyst from SEIU yesterday in my office, and I'm sorry if they went back to my office and gave me the follow-up, but I never got the follow-up that I'd asked for. And the discussion went back and forth on the fact that they'd be using the EOC's form, and they'd have to submit that to OSPA in terms of diversity, which seems very reasonable to me. But some of the diversity questions are not covered by EOC that want to be covered by the state in terms of gender identity and sexual orientation. I have no problem including those. How are we going to do that on a uniform basis? I could see someone that got hired first day on a job at a religious institution, and then they get a voluntary waiver or a voluntary kind of form to say, fill this out, might have a little apprehension or be worried about any form that came from the hospital and didn't look like it came from a government agency, or in this case, they talked about using the EOC form for the other diversity kind of voluntary requirement reporting stuff. How has this been worked out? What type of form would be used by hospitals to include this information? And to follow up on that a little bit, will that information be reliable because it is voluntary? How do you look at that and analyze that to see if that's even useful information when it is voluntary?
My colleague from Equality California is here. We have support from both Equality California and the LGBT Health and Human Services Network. I think it's important to note that federal law sets the floor, and California can work on top of whatever that floor is. In California, we're currently collecting patient data that includes sexual orientation and gender identity, pursuant to a bill that passed out of this House last year. And we believe it's important that if we're looking at demographic factors where we know that there are disparities, that we be inclusive, and so.
Well, no, I think. Yeah. I'm supportive of collecting the data. What I'm saying is, I didn't get a very good answer from your representatives yesterday on how they were going to collect the data, because originally they told me they were going to collect it through the EOC document. Then, in the course of our conversation, realized that the EOC document was not as inclusive on that information. So I'm not questioning. I don't know if you misunderstood me. I'm not questioning whether or not the data is valid to collect or whether or not.
Okay.
It's a worthy endeavor. I'm saying very, very specifically in terms of just, what would the form look like? Who's going to make the form? Is each hospital now going to be required to come up with a form of their own? Who's going to certify that form?
So the employer's already.
Please let me finish.
Yeah. Oh, sorry.
Is that form going to be done by each individual hospital? Who's going to approve the form? And then what kind of, in terms of that protections will employees have, because they're new on the job. If you get a form that looks like it's from a government agency, like a tax form or other types of employment forms that we currently have, that's different in my mind, and I could be wrong on this, than getting a form from the individual employer asking questions like that, even if they're voluntary or not. I just want to make sure new employees, whatever their orientation, whatever their race, whatever their ethnicity, are provided forms in a way, in a manner that doesn't create some type of situation in their own mind that would lead them to feel somewhat compromised by the situation.
So the bill is not prescriptive about what type of form and how it's going to be delivered. Employers currently collect data on, and it is voluntary, as was mentioned again by the opposition, on race, ethnicity, gender. And so this this bill is specific, however, that the data is voluntary, and so people are under no obligation, and I'm guessing that the employer would communicate that as well to their employees.
So just to conclude, the form, though, would be determined, created, and distributed, obviously, by the employer, which would be, in this case, each hospital independently.
Not even sure it would be a form. I mean, the employer just needs to collect the data and then aggregate it into pay bands. So it's not.
I think this section of the bill is lacking. I hope you'll work on this, Jimmy. Mr. Gomez, I think this is a section of the bill that could use a little bit more clarification. I think that this is a really important part of it, and I just think that I had this conversation yesterday, and I think the people I met with were very receptive. They told me they'd get back to me with an answer. I didn't hear back. I just think that this would be, as it goes forward into the next committee, an area where you could kind of codify that a little bit and make it clear for not only the hospitals but the employees that we're trying to help, what this process will look like, and give some clarity and hopefully make it consistent across the board. So whether you're applying at a hospital in my district or one in Mr. Gomez's district, whether that's a secular hospital or a religious hospital, that each employee will have a similar experience that's fair and transparent, and it gives them an option to provide the data that can be useful in the analysis that you want to see go forward. Because otherwise, this might not seem like a big deal, but as you go forward, I think this could become a huge issue on how the data is collected and really what is the purpose if the data is not valid. And if you don't have some kind of clarification in how you're collecting the data, I don't know if any of this is really relevant. So I appreciate the work today, and I look forward to supporting the bill.
Mr. DeBomne, I definitely appreciate your comments. We will definitely take your concerns into serious consideration as the bill moves forward. And I have no doubt that if the bill passes and we do satisfy your concerns, that the hospitals will implement it in the most ethical manner possible. So I'm not worried about that. But we will address that as we go on. So thank you so much.
Other questions or comments from committee? Okay, seeing none, We'll bring it back. I will be supporting the bill today. I do have a couple of concerns going forward. Some of the reporting requirements in the bill are based on pending EEOC policy that has yet to be adopted. So I think we have. So part of me wonders, is this a little bit premature? We don't have the EEOC policy yet, and we're asking for something else. But also, you may want to consider amending this in the future to clarify that the voluntary self-reported data is kept private. And if that was addressed earlier and I missed it, I apologize. It's been a long day. It's still a long day. So anyway, those are concerns that I have. So do we have a motion at this point?
Yes.
We do have. We have a motion. We have a second. The motion is do pass as amended to.
Second.
Oh, I'm sorry.
If there isn't.
Pardon? Well, apparently we do now. The motion is do pass as amended to appropriations. I'll ask Madam Secretary to call the roll.
Wood?
Aye.
Wood, aye. Mainshine? Bonilla? Burke? Campos? Chu? Dababneh?
Aye.
Dababneh, aye. Gomez?
Aye.
Gomez, aye. Hernandez?
Aye.
Hernandez, aye. Lackey? Nazarian?
Aye.
Nazarian, aye. Olson? Olson, no. Patterson? Patterson, no. Ridley Thomas? Rodriguez? Rodriguez, aye. Santiago? Stein North? Thurmond? Waldron? Waldron, no.
I'm going to get her on a vote one day.
One day.
Thank you.
So the vote stands at 6-3. We'll keep the roll open, and hopefully at some point we get a quorum back and can move on. So, Ms. Waldron, please. Those of you keeping track, we're still in double digits on bills to go.
This is the long. Did he say go ahead? I didn't hear that. Oh, somebody said.
Thank you, Mr. Chair and members. I'm here today to present AB 1764, California Health Benefit Review Program Financial Impacts. This bill would require CHBRP to study and consider a longer outlook data evaluation for the costs or savings on coverage or repeal of coverage of a benefit or service for a period of 2 fiscal years, and a longer range estimated outlook for 5 fiscal years if applicable. And our intent is to have this bill coincide with the renewal of CHBRP. Limiting savings and cost estimates to a 12-month period do not accurately reflect the benefits or impacts of the covered therapy. Simply looking at costs does not reflect the overall value, impact for patient outcomes, or the savings realized in a longer outlook. And it could go either way. It could show that the costs are higher when you look out, or, for example, initial costs of higher tier drugs may show substantial savings manifested after a 12-month estimate, including lower hospitalization rates, prevention of organ transplants, and may result in better quality of life and health outcomes for the patient at lower costs in the long run. Many California public agencies have realized the benefits of longer outlook estimates in their budgeting processes and have instituted 2-year fiscal budget cycles, and in many cases where large budgets are concerned, as in capital improvement budgets, a 5-year analysis and outlook. In fact, 19 states do 2-year budgets. We're just looking at an analysis for health, which would be 2 years or 5 years, which the data would most likely already be available when they're doing these outlooks. This allows agencies to better plan, assess, program, and facilitate the most efficient and cost-effective results. And this process would benefit cost, result, and value efficiencies in our state for healthcare access and outcomes. Healthcare outcomes cannot be quantified in a 12-month window,
As data analytics become more sophisticated, so should the value to individualized medicine and patient care. AB 1764 is supported by the California Chronic Care Coalition and Epilepsy California. I have here with me Mr. Shane DeSalle, Ph.D., who is a professor at Touro University, California College of Pharmacy, and president of Applied Pharmacy Solutions, as well as Jerry Jeffy with the California Chronic Care Coalition.
Thank you. Again, my name is Shane DeSalle, and I am faculty at Touro University, California College of Pharmacy, president of a research consulting firm, and chief editor of the International Peer-Reviewed Journal of Research in Social Administrative Pharmacy. I sat with significant interest a few moments ago to the discussion on BNIA AB 2209, particularly with respect to discussing the need for evidence in making decisions on healthcare services, because currently the California Health Benefit Review Program's window of 1 year for analysis all but precludes the proper evidence in decision making and the consequences and costs down the road for a particular healthcare service, product, or good. We need to rely on more accurate, quantifiable, and comprehensive measures to evaluate prescription drugs, procedures, and other medical services. And those mechanisms are indeed present and are become more refined by the year, by the month, by the day. Too often we examine only costs. We often don't look at outcomes, and when we do, we might be looking, unfortunately, at a very siloed type of approach, where we're not looking at the holistic sort of view. That is, for example, when we're evaluating a particular drug, we often consider only the drug spend. When we evaluate something in mental health, we often look at its impact only on mental health care, mental health services, and mental health costs, when in fact we should be taking a broad view of looking at the impact of a particular service, good, product, whatever that might be, on the entire medical care system, including drug spend, including hospital, including ER visits, including specialist visits, and so forth and so on. We need to take a more comprehensive view. An example of an appropriate outcome for many contemporary benefits or services is cost per quality adjusted life year. Our life year is added as a result of such benefits or services that are adjusted for the quality of those years added, as opposed to keeping someone alive in an unenviable condition, or actually that which makes care more difficult for them and unpleasant for the patient and their caregivers and loved ones. Thus, we need to frame the debate or evaluation of benefits or services around value rather than just costs. And the value takes into consideration the aforementioned and various health outcomes. Health outcomes, as mentioned by Assemblywoman Waldron, cannot be quantified in a 12-month study. Most effects of a benefit or service come downstream years afterward, sometimes even as long as 4 or 5, even 10 years afterward. Thus, the current method of evaluation by the California Health Benefits Review Program to analyze these within a 12-month period does not really portray an accurate picture. In fact, cost savings and improved patient outcomes, particularly value-added outcomes, might actually be realized if the analysis took a longer outlook. In other words, more money could be saved and more accurate decisions are made when taking a longer view. So a longer outlook of evaluation could not only benefit the patient in terms of their access to care and any cost sharing and outcomes of care, but also to health plans in their costing and the state Medi-Cal budget process as well. As long as we limit the analysis to costs and not benefits, outcomes, and value, and as long as we limit this to 12 months, we are not really getting an accurate picture. And as data analytics do become much more sophisticated with the use of things like Markov modeling and other types of tornado analysis and things of pharmacoeconomics would allow you to do so, we should definitely consider the value proposition to evaluate benefits and services for the good of payers and for the good of patients alike.
Great, thank you.
Mr. Chairman, members, Jerry Jeffy, representing the California Chronic Care Coalition. I want to make 2 brief points. Number one, 90% of the advocates that come before you that have a bill are always saying if you spend some money now, you're going to save a lot in the future. Well, now you can call them on that. You've got a nonpartisan organization that will look at beyond 1 year. And so if you spend $1 million now, will it save $10 million later on? You've got somebody to prove that for you. So that's really critical in your deliberations. Number two, there's an example where going out more than 1 year has made a critical difference, and that's the ACA. The Congressional Budget Office, when they were analyzing the bill, when it was before Congress, went out 10 years. And that was critical because the ACA has subsidies. There's money that went to the exchanges, which no longer are going to them now. And there's the phase in and then the phase out of the Medicaid expense. So if you just looked at 1 year, you wouldn't see the real cost of the bill. So going out long term is absolutely critical, and we'll be able to have that in California.
Thank you very much. Others in support of the bill? In opposition? Or?
Well, Mr. Chair and members, Nick Luizos with the California Association of Health Plans. This is a recently amended bill, so we don't have a position at this time. We would just say that our members are assessed a fee for this program, so we'll be analyzing the bill moving forward with that in mind and reserve our right to take a position in appropriations.
Sure. Thank you.
Epilepsy California in strong support of the bill.
Thank you. Anyone else? In opposition? Anyone in opposition to the bill? Bringing it back to the committee, comments? Anyone? I have some comments, and then I'll give you an opportunity to close, and that's probably maybe a little out of order, but I actually agree with the premise for the bill. I really do. I think it makes sense. I think that looking at longer term outcomes is really, really important. Not just 1 year, but further out. The problem I have with the bill, and as we've gone back and forth on this, is the timing. CHBRP is set to sunset, and I'm just not comfortable that putting an additional burden on them at this point is the right time to do that. In the sunset review process, we'll be able to assess this and actually make those recommendations, and it may not really even need a legislative fix, to be quite honest with you. So if it doesn't, I'll be one of those people that will be happy to support what you're doing, because I actually believe that you're right. When we'll review these additional requirements during the sunset and look at the funding that's going to be required to do that, and at that point. So at this point, I have a none recommendation, but I won't be voting in support. And it's really not about the content of the bill. I really like what you're doing. It's about the timing. So I will ask for you to close. Excuse me. I'm sorry.
Okay. Thank you.
I said I was going to do that.
No, I appreciate that, and that's why we're looking at this point upon renewal. So working with the committee, we just found out that of that issue, so it's too quick to get amendments in. But my fear is that if we don't get something substantive in statute or moving down the path, if it were to be renewed, then it's another whole year of legislative, working on another bill to get the 2-year study put in if it were to be renewed. So it was kind of like a stopgap to have something in place or moving down the pike that in case it is renewed, since it is going to sunset January 2017.
Yeah, I appreciate.
And then the other thing I was curious to see, and I went on the Medicaid.gov page, so that's the national Medicaid, and they do a 2-year fiscal budget. So I found that to be interesting too, because a lot of the times, now 4 years I've been trying to pursue bills that would benefit the patient in the long run, save money. And, we've said those things over and over and over, but we have not been able to study it. And there's always that block of 12 months, and how can we go beyond that? So that's what motivated us for the bill. And with the fiscal analysis process currently used, we're potentially limiting access, outcomes, savings, and patient care by limiting the study to 12 months. And I respectfully ask for your aye vote.
Thank you. Madam Secretary, call the roll, please.
Wood?
No.
Wood, no. Mainshine? Bonilla? Burke? Campos? Chu? Dababne? Gomez? Hernandez? Hernandez, aye. Lackey?
Aye.
Lackey, aye. Nazarian?
Aye.
Nazarian, aye. Olson? Olson, aye. Patterson? Patterson, aye. Ridley Thomas? Rodriguez? Santiago? Steinnorth?